Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge
Time
that is
is
going to be shared by our keynote
6:00
speaker Dr.
p.m.
for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Professor Dr. Nishant Kumar. Sir is MBBS, DA, DNB, MNAMS, Professor, Department of Anesthesiology at Lady Harding Medical College and Associated Hospital. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is innovation in airway management for challenging cases. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
I'm sorry, but you'll have to excuse me for my bad throat. Uh, Thanks to daily pollution. Okay, so the topic today is innovations in airway management for challenging cases. Now we all know that the we can have the airway difficulty which can be anticipated or and it is and unanticipated. And as you can see in this corner here, this was the earliest laryngoscopy and intubation position that was performed with the earliest of the laryngoscopes. We have certainly come a long way from this. Now, before we proceed, we know that we have to have a plan for anticipated difficult airways. So, when we are proceeding with induction of anesthesia, you should always review what is your primary airway management strategy. We pre-oxygenate and induce anesthesia. If the airway is successful, very well, you continue as planned. But if it is not successful, if you're not able to put in, the first thing that we have to see is whether you can ventilate adequately or not. Now, this is nothing new, but a simple difficult airway algorithm that we have to follow. If the ventilation is adequate, fine, but still consider calling for help because your initial plan was unsuccessful. And then you can take less than 3+1 attempts and always keep a watch on SpO2. So we have the option of an alternative device, we have the option of a patient or an invasive airway. Now, if the ventilation is not adequate, now that is a worst scenario where you cannot intubate, cannot oxygenate. So that is where you have an emergency pathway. So first you try with a full face mask, if not possible, supraglottic airway, tracheal tube, and in spite of all these, if ventilation remains inadequate, we have to go in for emergency invasive airway, rigid bronchoscopy, or even ECMO. But whenever you face a difficulty, the first thing is you should call for help, especially when ventilation is not adequate. Even if ventilation is adequate and you are facing difficulty with the original plan, please consider calling for help as early as possible. Okay, so in pediatric patients, again, you have to have the same rationale and you call for help wherever you feel that you are having a problem and not more than 3+1 attempts. And you can always go for advanced techniques such as rigid bronchoscopy, emergency invasive airway, or an ECMO. Again, remember, pediatric patients are much more prone to hypoxemia, so oxygenation is a must, and you should always consider a supraglottic device if face mask ventilation is not adequate. So we all are conversant with the traditional techniques, but we do have certain newer devices which have come up, and I'll broadly classify them as supraglottic devices, the video laryngoscopes, devices for one lung ventilation, and the robots. So supraglottic devices. Supraglottic devices can be a substitute for your face mask when you are having problem in ventilation, and obviously they can be used as a sole airway technique or a definitive airway technique for certain surgeries. So whenever you have a problem with the face mask ventilation, or if you cannot intubate, see whether you can proceed with the supraglottic device or not. Now the problem with the supraglottic devices, we have the first generation and the second generation devices. The first generation devices do not have a gastric tube, so there's always a risk of gastric aspiration and regurgitation and aspiration, whereas we can decompress the stomach with the use of second generation devices. Uh, the other problem is that the supraglottic device may not conform exactly to the anatomy of the larynx and may leave something undesired. Okay, the ventilation might be possible, but conducting an entire surgery is a bit iffy because the fit is not so good. and you're not sure whether it will get displaced or not, and whether the patient is getting adequately ventilated or not, although the saturation and oxygenation might be maintained with the suprachoroidal devices. So, is there anything, any advancement which can tell us whether our suprachoroidal device is in place or not? And also, please remember, suprachoroidal devices have been used in the past as a conduit for your endotracheal intubation as well. So, traditionally, what we do is we put in a suprachoroidal device, we pass an endotracheal tube blindly and see whether we are able to ventilate and whether the tube has gone inside the trachea or not. The other option is to pass the endotracheal tube through the suprachoroidal device using a fiber optic bronchoscope, but then the availability of fiber optic bronchoscopes is, as you all know, is not they are not omnipresent. So, do we have any suprachoroidal devices which will tell you whether your placement is correct, whether you can continue your surgery with a good fit with the suprachoroidal devices only, or you can use it as a conduit for your endotracheal intubation without the use of without the use of a fiber optic bronchoscope. So the earliest one was the LMA-C trap. It was nothing but an intubating LMA with a camera attached at the tip and a screen. So you could exactly see where your the laryngeal cuff was placed vis-a-vis the glottis. And obviously, when you're passing the tube through this, you can see the tube passing through the vocal cords. So but the problem was that you had to have a dedicated endotracheal tube with an atraumatic tip, which was silicone based, and the airway was fully autoclavable, elevating bars, just like an intubating LMA with a camera and a screen. Unfortunately, sorry, this is no longer in production. So, with the same idea, now we have what we have is a total track. So, this comprises of three parts. We have an introducer, a laryngeal mask, and a video track on which can be passed through one of the tubes of the LMA. So this can be used alone as a suprachoroidal device or along with a detachable camera and a screen which passes into this. And once it is placed, obviously you can see whether it is perfectly fitted or not. Unfortunately, this cannot be used for your uh, intubation purposes. Then we have another one, which is the FACOVLM disposable video laryngeal mask. It is disposable, that one is reusable. In this, you have again a channel here from which the video slit goes, and it is attached to a screen with a pilot balloon and uh, a channel for deflating the stomach, as you can see here, and then you can see the tube also passing through it. So this can be used for intubation as well. Now, we all know, as we see, that a change of blade is warranted. Now, this can be used, the suprachoroidal devices, as I showed you, these can be used for ventilation and for intubation as well. Now, when the second step is, if ventilation is adequate and you're not able to intubate with a conventional blade, going for a video laryngoscope. So with this, you can see clearly. So what is the genesis of video laryngoscope? These begin with the lighted stillets. So we had the track light, which had an angle of 90 degrees. So what you did was you made the room dark, you passed it blindly, and you saw this light passing through the center and at the cricoid. And once it was seen at the cricoid, you know that you had entered the trachea and you slit the tube in. Similar was a light band. Unfortunately, these two have also been discontinued now and are no longer available in the market. So while video laryngoscopes, let's go a bit in the history of intubation. So the sniffing position was first described by Green in 1852. Remember the first picture which I showed, and that is how the intubation. So that is how your intubations were performed earlier. The recumbent position was first used by Chevalier Jackson in 1913. So as late, almost 50 years later, it was used in the recumbent position, and the alignment of three axes by pillow under the occiput or the sitting position in the recumbent position was first proposed by Bannister and Macbeth in 1944. angle of larynx to heart palate is roughly 36 degrees. That is what they calculated. But that is considered one of the earliest fraud in the history of medical literature, because once you see the X-rays that is published, it is not possible that the laryngoscope is in the mouth. So to come up, the alignment of the three axes is a myth which has been going on for the last 80 years or so. Now, this was first proposed by Adnet et al. In 2001. Sniffing position is as good as a simple extension. You do not need to align three axes. In fact, you cannot align the three axes. And this was proven by the MRI studies. Now, if you see here, what we have is the laryngeal axis, the pharyngeal axis, and the oral axis. And this is the line of vision that you see. So if we consider the optics, it is mostly the line of vision which is most important. So this is in the neutral, this is an extension, and this is in sniffing. So if you see, the line of vision is most conducive in the extension position rather than the sniffing position. And if you see, you can see the glottis more clearly from the line of vision, LV, not the laryngeal axis or the mouth axis or the pharyngeal axis. And whatever position that you obtain, these cannot be aligned. In fact, this is what they have said, that these are the angles, and it is the delta angle. If you see here, the delta angle is here, the laryngeal axis and the line of vision, which is the least in extension and sniffing, almost the same. That is why it was said that whether you use the extension or the sniffing position, the line of vision is the same as the laryngeal axis, whether you extend or perform or you achieve a sniffing position, which is around 29 plus minus 10 degrees. So now, why the conventional laryngoscope? Now, the normal Macintosh has a curvature of 23 degrees. So that still leaves a deficit of 6 plus minus 9 to 10 degrees. And that is why you have to lift up to align the vision, LV and the LA, so that you can pass the tube in. Now, why a video laryngoscope? So if you see here, classic Macintosh is 20 to 23 degrees, and we have the laryngoscopic blades. The earliest one which we had was the Bullard, and then came the TrueView, which used a system of prisms. And video laryngoscope usually give you a virtual image rather than a real image. So actually, the image is here, but you see it here. So that is what we learned in optics. It's a virtual image. The image is here, but we see it here, and it is in the direct line of vision, line of sight, as you see here. And this roughly comes out to be 42 plus minus 2 degrees. And more the blade is angulated, the easier is to see the glottis. That is why the main problem with video laryngoscopes is you can see the glottis, but it is very difficult to put the tube in. So the difficulty is in putting the tube in, and not in the patient where your video laryngoscopes. Now that is why we have the different laryngoscopes, as I'll be discussing later. So the earliest video scopes were the Bonfils retromolar intubation fibroscope. So this was a rigid still kind of a thing. Remember we talked about TrackLight and Lifon, but those are a bit flexible. And this one is rigid. Now this has come up in a newer version, and the first video laryngoscope was a Bullard laryngoscope with a channeled and a preloaded endotracheal tube, as you can see here. So the video laryngoscopes can be classified as Macintosh blade shaped. No different. They just have a camera attached at the end, at the tip, and what you see, you can use them directly also, and you can use the screen also. We have the angulated blade, rigid, and channeled rigid. Now, when we talk about the Macintosh blade shape, they're same as the traditional Macintosh blade, but they have a camera attached, and you just see the image on the screen. So Karlstor's VMAX, CMAC, McGrath map, and you can have the direct and indirect glottis view, and these do not require a stillet. So more or less the same thing. Angulated blade, as I said, you require an angulation of more than 42 plus minus 9 to 10 degrees to create a virtual image, so that you can, that is more so in difficult airways. So we have the Karlstor's D blade, CMAC D blade, which is around 60 degrees, McGrath Series 5, bright scopes, preview devices which have now come up with an angle of 48 degrees and AP scope. There are many in the market which are hyperangulated. Hyperangulated means that more than 23 to 26 degrees, and they provide a very good glottis visualization. But you require a stillet because they don't show the glottis where exactly it is. It creates a virtual image. So you have to manipulate, and it is much like guiding the tube towards the vision that you see. And it is potentially difficult to direct the tube towards the glottis in these angulated rigid blade video laryngoscopes. So this was also in part uh, overcome by providing a channeled hyperangulated or angulated video laryngoscopes in which the tube is preloaded onto the video laryngoscope. Then you introduce it, and since you can see it, and as you know that the tip of the laryngoscope blade lies in the vallecula, you just slide the tube below it, along the lower surface of the blade. So we have air track, Pentex AWS, and Ping Vision. So you have improved glottis visualization, and ETT is inserted by the guided channel, and you have a better success rate. Sorry. So as you see here, this is a video laryngoscope, a normal Macintosh shape. So whether you're using a camera or not will not make much of a difference. And if the intubation is difficult, you may require a stillet, but normally for these video laryngoscopes, stillet is not required generally. So here we see the hyperangulated. You can have disposable or reusable things. And for these, if you see here, the angle is much more, and you require a stillet for these video laryngoscopes. It's a must, but they definitely improve the vision. In fact, if you are having a difficulty in vision, it is the angulated blades which should be used. And then here are the channeled ones. Now, if you see, these are angulated, hyperangulated, and the tube is loaded. And since you see it, and this tip lies in the vallecula, the tube is just slid into the glottis below the blade. Under vision, of course, and here is the screen that you see. So, AirTrack, Pentex AWS, and King Vision, they can be, they are the commonest examples. But although there are now many video laryngoscopes in the market, we have a problem of plenty. Now, this is just a video, small video, which you can see. We are using a normal Macintosh blade. If you see, it is used from the midline. Remember, the video laryngoscopes are used in the midline. Here you can see the posterior part. He's maneuvering it. You can see the glottis. The view is still not good. Okay, now the tip is in the vallecula. He has used a still on the glottis. The slit is removed, and the tube is pushed under vision, and then the plate is removed. So this is the oral intubation with the CMAC laryngoscope that we have shown here. The other one, okay, so this one is a nasal intubation using the same plate. If you see here, you will see two different views. Now, what we have done is we have lubricated the nostrils. We are just putting the tube blindly into the nasopharynx. Okay, the laryngoscope is introduced into the vocal cavity. You can see the epiglottis. Even after lifting here, remember this is a normal blade. A burp is required here. So burp is 75% of the glottis here, or this is mostly to be. The tube is being pushed in. Now, if you, as you can see here, so we are using a Magels to bring it down, and the tip is across the vocal cords, and then it is being pushed in gently, as you can see from the top, and the tube has gone in under vision into the glottis. So this is how nasal intubation is performed using video laryngoscopy. Now the newest one, as I said, the Bonsall's retromolar intubation this thing. Now this one is a rigid video stillet with a camera, and this can be used for minimal mouth opening, and the mouth opening can be as good as the size of the tube that you have to introduce. And if there's a retromolar space, you just pass it retromolarly, that is behind the molar teeth where you get the space, and you need the mouth opening should be as wide as the diameter of the tube that you want to put in. So this is again very useful. It is a rigid stellate with the tip slightly flexible, and you can mold it, and you have a screen attached, and you can put in the tube directly. Okay, now the gold standard flexible endoscopes. This one we already know. Then these were the fiber optic bronchoscopes, which had fiber optic fibers in which, and basically very thin, fine glass this thing, and used optics. We had to be careful not to bend them or the fibers would break. These are bulky. You can see the camera here with a suction port and everything. Now the newer ones are the flexible video endoscopes. Now these are just flexible tubings with a camera attached at the tip with electrical connections. So the camera just relays the image on the screen, again a virtual thing. So we might have reusable ones and the disposable video endoscopes. Many companies are marketing it now. So and these are just like the conventional fiber optic bronchoscopes, but these are video endoscopes because they have a camera at the end and just electrical fibers, so you can bend them, you can you need not have them straight, and they are less driving and lighter in weight and easier to manage. Now the problem is that with this you have with these sorry, the tip can be moved only in the anteroposterior direction. So if you have to go left or right, you have to rotate the entire scope, and then you lose your vision. So we have the fibrosa, and now Ambu has also come up with almost a 360-degree mechanism where you can have and if you see this here, this is a 360 degrees. With a single click, you can use these. This is fibrosa. In fact, this is one has a 360 degree. The ambu scope has two levers in which one goes up and down. With the other lever, you can make it left or right. So it is like this. The movement is like this and like this without actually rotating the scope. So that is how the flexible. These are actually video endoscopes. The scope is I've used the wrong. That is what they use, but these are video endoscopes with the camera at the tip, and you can rotate left and right and up and down. So you have movement in three planes practically. Now we all know that whenever we go in for thoracic surgeries, one lung ventilation is required, and it's very difficult to have a vision beyond the carina without an endoscope or a fibroscope. So how do we do it? Just a look at the difficult airway management when we require one lung ventilation. So if it's rejected, the same way you do fiber optic assisted tracheal intubation, you either put in a single lumen tube or put in a double lumen tube. If you're able to put in a double lumen tube, well and good. If not, you put in a single lumen tube, use a bronchial blocker, or you use an exchange to double lumen tube over airway exchange catheter, and you're going for one lung ventilation. But for all these things, you require a fiber optic bronchoscope. If it is unpredicted, again, face mask, laryngeal mask airway, the same thing. Either you use a single lumen tube or a DLT and then going for a one lung ventilation, but then you require a fiber optic bronchoscope to confirm the position of the double lumen tube, or if you're going for an endobronchial intubation also, you may require a fiber optic bronchoscope to guide the tube into the correct bronchus. So now, this is something called as ETVU tracheoscopic ventilation tube TVT, in which you put it beyond the carina, and then again this has a camera tip at the end, and you can attach it to the screen. So once you're in the trachea, you can now guide it looking at the screen whether you want to go into the left or to the right or to the bronchus. Simple. So it becomes like an endobronchial intubation as well. Similarly, we have tracheoscopic ventilation double lumen tube. Now here the catch is that we have the camera at the bronchial end. So we know where the bronchial end is going, and similar to above, once we are in the trachea, we use this camera and the guide on the screen to maneuver our tube, knowing the angle where it is positioned, whether it's a left bronchial left double lumen tube or a right double lumen tube. So we have a camera attached, and under direct vision, we can go as far as possible. In fact, this offers a good margin of safety for the right double lumen tube as well as for the left also, so that we don't block any of the secondary bronchi. Robots, so that is the future. The machines are rising, and maybe in another 5 to 10 years, it will be the robots will be performing the airway management. So the earliest prototype was this Kepler robot, in which it was just an arm and joystick, and you stand at the end and you maneuver the video laryngoscope and maneuver it, see it on the screen, and just like playing a video game, you see, maneuver, manipulate, left, right, up and down, anterior, posterior, all the three directions, lifting up, and then you put in the tube using the Kepler, the first one. The second one is this one is the reality, robotic endoscope automated via laryngeal imaging for tracheal intubation. Now, this one is that this recognizes, this has again a camera, it recognizes whether it is there or not, and you can actually do it. So what you can do is you put in this thing 1, 2, 3, and it will tell you stage 1, okay, no more lifting is required. Stage 2, the glottis is seen, it will penetrate, and then the tube is passed when there is stage 3 and stage 4, but then you have to put in the tube in this particular case. This is a robotic endoscope, and it will tell you and readjust whether you can see the image or not, and it will tell you where you have to or how you have to manipulate your scope so that you get the best vision. So this is just a robotic endoscope rather than a robot per se. Now, this is an automated intubation robot system which has the laryngoscope, a camera, and a force sensor, and a tube also with the depth camera as well, with wheels and a robotic platform. So what it does is, you give anesthesia, robot reaches the patient, it recognizes the face. Laryngoscope moves to the face. It recognizes the lips and the mouth. Laryngoscope inserts without contact, goes in, identifies, and lifts the epiglottis. Once the glottis is visible, it grabs the tube moves along the laryngoscope, and it's parked in front of the glottis. Again, it recognizes whether it's in the right position or not, and then it enters the trachea, and then it exits. So, this is practically the uh, actual robot which is used for intubation, and it does it on its own. Then we have the remote robot assisted intubation, in which the anesthesiologist is sitting outside, and it has an arm, posture structure, tongue depressor, and it can be controlled from there. So it has a tracheal tube, an embedded tube tip camera, and again it can move in all three directions in all three planes and 360 movement with a tongue depressor. Now, in the laryngoscopic group, total time to intubation was 53 seconds, although in the robo group, it was 74.6. This was just a pilot study. But if you see, first attempt success rate in these mannequins was 80% with the robot. And over these were paramedics actually, not anesthesiologists. But you see, as compared to paramedics, the robot performed almost 90% this thing. And complications, minor complications, nothing major, but 10% complications were required. And if you see here, uh, in this again in the patient, if you see here, the hemodynamics were more or less the same, and the number of attempts were lesser with the robot. So these are some of the innovations innovations that have come up, and definitely in challenging cases, these are the innovations which can be definitely be useful whenever we are facing a difficulty. And equipment, the airway management is widening. and we have to be abreast with the latest technology and knowledge. With that, I'll end my talk and thank you very much.
Thank you so much, sir, for this wonderful presentation. We do have some question if you'd like to take that up.
Yeah, sure.
So, sir, the first question is, what are some recent innovation in airway management that have significant improved outcomes for challenging cases?
So as I've said, we have the supraglottic devices, we have devices for one lung ventilation, video laryngoscopes, and the robots which have come up.
So, there is another question. How do this innovation address specific challenges or complication encountered in difficult airway scenarios?
So as I said, now with the use of technology and the optics, it's just simple physics and optics. You have to have line of vision. You have to you're supposed to identify the structures and then put in the tube in the right place. So that I think I've explained the entire thing in the talk just now, and how the robots can also help and aid in intubation and securing the airway.
So, there's one last question. What role do interdisciplinary approaches play in the development and implementation of this innovation?
Okay, so interdisciplinary, the main thing is you have to have a good knowledge of your physics, electronics, the biomedical part, and definitely it is the clinicians who have to work in close tandem with these developers, because we have to tell them their needs and then they can design. So it is, you have to work in close proximity with the developers, the biomedical engineers, and you yourself should have a very good understanding of the anatomy and the processes involved in the management and the challenges that we face. Okay, difficult airway can be a difficult ventilation, it can be a difficult intubation, difficult laryngoscopy, or a difficult intubation and difficult front of neck access. So now, as I said, if your mouth is not open, we normally go in for video laryngoscope, but now this video stillet, this can be used as a rigid guide. In fact, if you're having difficulty and if there's trauma or anything, so these are the advances that are being made, and we can make use of technology to use them in our challenging cases.
Thank you so much, sir, for answering all our questions. That's all from our audience. Before concluding, sir, any take home message from your end?
Uh, these aids are good, but then you should know the basics and you should master your basic skills before running after technology. You should have a sound knowledge, a sound skill set with insertion of supraglottic devices. Mass ventilation comes first, then supraglottic devices, and obviously intubation with conventional laryngoscopes. So that is a must before you go in after the technology and master these additional techniques. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you.
Thank you. Thank you so much.